What is important, and we spend the whole first section of my book is understanding one's body. Because when there was a survey in London where you think, okay, there are a lot of younger people and they should know, 1 in 2 women did not know where their cervix was. 1 in 4 women in a survey in 2020 did not know where their vagina was. 1 in 10 women did not know where their reproductive organs was. So these were not like 200 women, these were 2,000 women that were surveyed. And I find that in my own practice as well. You have these lawyers and doctors even who don't realize that the menstrual cycle should be between 24 and 35 days, and that missing periods is not acceptable. You may have PCOS, you may have an ovarian tumor, you may have an eating disorder, you may have be exercising too much, you may be having a completely other medical condition. But if you're somebody who's regularly having delayed periods beyond the 35 days, or you're having frequent periods under 24 days, if you are having periods coming every 3 months, and it's really important to understand that that needs to be addressed.
Doctor's Kitchen. Recipes, health, lifestyle.
I want to dive right into this. At the start of your book, you describe PCOS as an epidemic. And I was actually quite shocked to see that in an economic meta-analysis in 2021, PCOS accounts for $8 billion in healthcare costs annually in the US alone. Why does it cost this much? And how come I wasn't aware of this?
That's a great question, Rupi. Actually, most people aren't aware of this, including doctors and health professionals. And that's because 3/4 of people with PCOS never get a diagnosis, first of all. But when they do, the effects, the short-term, medium-term, and longer-term effects cost the economy, because half the women with polycystic ovary syndrome by the age of 40 will have type 2 diabetes if they're carrying excess weight. Gestational diabetes is a real problem. That is pregnancy in diabetes, diabetes in pregnancy. As well as later on, womb cancer, type 2 diabetes, increased risk of heart disease. All these things add up. So although they may not have had a diagnosis of polycystic ovary syndrome, the results of having the condition end up costing the economy. So we're not doing prevention. We are sort of firefighting afterwards rather than, moving in much earlier. 1 in 10 women are actually affected by the condition, polycystic ovary syndrome. But in certain subgroups, the Asian population, that is so sadly not been researched properly at all. Those who are from other ethnic minorities, groups, Hispanics, African Americans, they all have a higher incidence of polycystic ovary syndrome. Those who are struggling to conceive, those who are carrying excess weight, the incidence can be as high as 1 in 4. That is not just an epidemic. I would say it's a pandemic, but nobody is talking about it. And that's why one of the reasons we wrote the book, So we wanted to reach people who either didn't know they had the condition, or if they did, nobody had joined the dots, and they were being either dismissed by their health professionals to come back. I have seen so many patients being told, come back when you want to get pregnant, when they have missing periods or irregular periods. And so these are the things that we felt, I wrote it with my daughter because I actually started writing a general book. I had been wanting to write a book for years and never got around to it with my busy lifestyle and my job and career and managing a family. And when I finally got down to writing it, I started writing a general book. And Rohini, my daughter, who's a co-author, said, Mom, why are you writing a book that has got 2 pages on PCOS, 2 pages on endometriosis, another few pages on menopause, when you have 35 years of experience and you are specialized in all these areas? And she herself has PCOS, and it took a long time to diagnose, despite being the daughter of a OBGYN. And so we wanted to write the book that she wished everybody else could have, because she obviously had me to help her. So that's how the book came about.
Yeah, it's amazing. I met your daughter briefly at a Romy Gill's book launch a couple of months, maybe it was a year ago now. The time flies post-pandemic.
Time flies since
Yeah,
COVID.
yeah, and she's so lovely, and you can tell it really comes across in how she's shared her story so bravely in the book, and we'll get to your sort of your own story as well. Yeah, no, I think it's a lovely combination of the mother-daughter and having that book that she wished that she had. Let's dive into some of the elements that are driving this disorder, because the prevalence, or the increase in prevalence, particularly amongst ethnic minorities, I think is seen across lots of different conditions that we see, some of which are related to PCOS. What's driving this condition? I'm assuming it's going to be a genetic component as well, which is explaining this. But give us a sort of a summary, a sort of a bird's eye picture
Yeah.
of what we know about what is driving PCOS.
I think I'll start off, Rupi, just by explaining what the condition is, because there may be listeners who may not actually know what PCOS is, which is polycystic ovary syndrome. It's the most common hormonal condition to affect women worldwide. And when I use the word women, I do want to stress that it's anybody who has female reproductive organs or has been assigned female at birth, because that is important. However, you may choose to identify later. And it affects, as I said, 1 in 10 women officially, but we think in certain subgroups is 1 in 4. So it's the most common endocrine condition. And I want your listeners to think of it as a cousin of type 2 diabetes. And so once you understand that it's a complex condition, it's a genetically driven condition. So you will have family members often, if you take a good enough history of a mother or a sister, because that increases your risk. And epigenetics and genetics comes in because it also works on the way the insulin receptor is modulated and things like that. But interestingly, there was a wonderful study of 172,000 men, I think, in an Oxford study, which said that men also show the characteristics of polycystic ovary syndrome. Now, that is something that is really interesting. And what do we mean by that? So PCOS is a hormonal condition, but it doesn't actually the ovaries are not diseased. It affects the function of the ovaries. So it is an endocrine condition. It is managed a lot by gynecologists, but really it's an endocrinologist who should be managing this condition. And men have symptoms like metabolic syndrome. They have raised triglycerides, increased waist size. They have early frontal loss of hair or frontal balding, as we say, type 2 diabetes, increased risk of heart disease. So if you're a man listening and you have a mother or a sister with PCOS, you need to also take that extra care, because you also may have those symptoms of PCOS, because PCOS is mistakenly named polycystic ovary syndrome. There are no cysts in the ovaries. What those are immature egg follicles that you're born with, and every month one of them is supposed to race to the top and release its egg, which is called ovulation, and that gets disordered because of the signals coming from the brain and from insulin resistance, which tends to be the main driver. So your question was, what is actually driving this condition? About 3/4 of people with PCOS have a background of insulin resistance. 8 out of 10 women with PCOS actually carry excess weight, but 20% don't. And even some of them will have insulin resistance. And insulin resistance, for your listeners, is basically a situation where your cells in all your body, whether it's your muscle, whether it is everywhere, every single cell in your body becomes resistant to the action of insulin. So the insulin is a hormone. Hormones are chemical messengers. They are basically released in a certain organ. Say, for example, the pituitary gland in the brain releases hormones like FSH and LH, or the pancreas release insulin, and they exert their action in a distant organ. That's what a hormone is. It's a chemical messenger. So when your body or the cell is clogged either, for example, with fat, or the insulin receptor gene is causing a defect in the receptor, which is where the insulin hormone will attach itself. What happens is the cell says, no, I don't want you to come in and move the glucose in. So what happens is the body then sends a message to the pancreas saying, produce more insulin, not actually getting the message. So the insulin levels rise. And as insulin levels rise, what happens is there is another hormone called insulin-like growth factor, which directly stimulates the ovaries to produce more androgens. Testosterone is what you would have heard of. And so that then results in many of the signs and symptoms of PCOS. So insulin resistance, when we treat it, however, and we'll come to that, we think that is one of the main drivers, but it's not the only driver. But it has to be in the background of genetics. So, I want people to realize that it is a genetic condition that is hugely influenced by the environment, by the lifestyle. And it's not just what you eat, or it's also, the pollutants in the atmosphere, in what you're eating from. All these things are equally important. Otherwise, I find people tend to blame themselves. Oh, it's a lifestyle condition, so it must be that I have done something wrong. And that is a big problem, because if you don't start talking to yourself with compassion, you're going to go down this rabbit hole of it's my fault. And, historically, women have always been in that, made to be smaller than themselves, immigrant women, especially in this country. So, and women all over. So I just think it's important to understand, not to spend time blaming yourself. Speak to yourself as if you would to a loved one. Yeah. So I want people to understand that lifestyle doesn't mean it's only what you are actually doing. Yes, there are things that you can do.
I want to go back slightly actually to the PCOS, because I think that's going to be pretty surprising for a lot of people, that there aren't cysts in the ovary, right? And that this is actually a hormonal driven issue. This is an endocrine problem that is commonly managed by OBGYN, as you just mentioned. How did we get to the situation where we describe it in the description of the condition as polycystic ovary syndrome? How do we get to this point? And maybe we should be renaming it. I'm not too sure about your thoughts on that.
So there was a big move to rename it as reproductive metabolic syndrome, but it's only just started getting airtime, PCOS. So I think it was then decided, leave the name alone. And the name really comes from, Rupi, when you look at one of the criteria for diagnosing PCOS. So in an adult woman, you need to have 2 out of the 3 criterion to be met if you're going to diagnose somebody with polycystic ovary syndrome. PCOS is a diagnosis of exclusion, which means that when a patient comes to see me, I have to be very careful before I give them a diagnosis of PCOS, because there are other conditions that can mimic it. And so you have to rule out things like ovarian tumors, adrenal tumors. You have to rule out hypothalamic amenorrhea, especially in a lean PCOS person, because it may be from over-exercising or from eating disorder and other conditions. So it's really important. Cushing's syndrome, or non-congenital adrenal hyperplasia. There are many, many conditions. So really a good endocrinologist and a good OBGYN will not just label somebody, because misdiagnosis can also be harmful. You don't want to overdiagnose the condition. And so what happens is you need to fulfill these 3 criteria. And what are these 3 criteria? The first one is one that most people would have heard of, is missing periods or irregular periods. Now, a normal period should be between 24 and 35 days. Your period should be coming 24, 25, 26 days, 27 days, or 30, 31, 35. It shouldn't swing wildly. You shouldn't be missing periods. And if you're missing periods, especially for more than 3 months, or your cycles are 40 days, 45 days, that's not normal. That's not the normal signal that is going through your body. So that is known as anovulation. Your ovary is not releasing the egg every month. And so that is resulting in these delayed periods or missing periods. That's the first criteria. That's a clinical criteria. I just need to ask the patient, tell me your menstrual cycle. And every woman should be tracking her menstrual cycle from the time she starts her periods till the time she finishes. Then the second criteria. So the first one is not releasing the egg and period issues. The second one is signs of androgen excess, which basically means that you would have heard, and this is something that really saddens me a lot, because people use the word testosterone as a male hormone.
Yeah.
Women in the reproductive age produce 4 times as much testosterone as estrogen. Most doctors don't know that. And so testosterone is as much a female hormone as a male hormone. And it depends upon your age, your gender, your stage of life that the testosterone levels fluctuate. But so the most famous of all the androgens is testosterone. There are others. And what happens is there can be signs of androgen excess, which is a second criteria. And how would you notice it clinically? Women may notice that they have adult acne, acne on their chin, bacne on their chest. They may have hair where they don't want it on their chin, on their chest. They may notice scalp hair loss. So these are the critical signs. And so you can have both these, the first criteria of missed periods and acne, that may be enough to give you a diagnosis of PCOS, but you have to complete the whole circle. So you would do certain lab tests, which will look at testosterone levels, the amount of free testosterone that is going around, that is not attached to a protein by the liver. So there are certain lab tests that we also do that could be part of the second criterion. And then the third one is where the name came from. It's an ultrasound. Now, a pelvic ultrasound, and you should have a vaginal ultrasound only if you've never had penetrative intercourse. It should never be done in somebody who's never had vaginal intercourse, and so what is important to know about the ultrasound, you can do it abdominally as well in young girls. You want to look at the ovaries, and there's a particular pattern. There are these little empty, immature egg follicles that haven't matured, arranged in a pearl necklace or a rosary appearance. And so they appear like these little fluid-filled cysts, but they're really empty, immature egg follicles. And so that is a name where polycystic ovary came from, and also the volume is increased. Now, we don't use ultrasound or polycystic ovaries in teenagers, so you're not allowed to use ultrasound as one of the criteria. You have to use the first two. Why? Because adolescents actually have multicystic ovaries naturally and normally, and so you might get confused. So that's where the misnomer of polycystic ovary came from. Similar thing is, people often say, I have pain with PCOS. Pain is not really a feature of those cysts. They don't grow to any size. They're not big ovarian cysts or things like that. So if you are having pain and you're listening to this and you've been diagnosed with PCOS, that is not normal. Painful periods is not normal with PCOS. You should look out for is, do you have a coexisting condition? Do you have endometriosis or fibroids and adenomyosis and pelvic infections and things like that? People often just will put one label, and then you're suffering for a long time. You may have pelvic floor dysfunction, and that's what's causing the problems. Body image issues, so many situations. And we talk about all this in the book, because while the book is a deep dive, people can just pick up and read different chapters that they want to, simply because, you want to learn more about the condition, the bits that affect you. So that's what we did. We tried to break up the book into different bits with case studies.
Yeah, that's going to be exceptionally important, I think, for people who are trying to join the dots, as you described earlier, that Rohini was doing. Just on the point around pain and painful periods, because I think that is a very common misinterpretation of what PCOS is, even amongst healthcare professionals. I think they would will the painful periods away with a total diagnosis of PCOS. Do we have a sense of the coexistence of PCOS with other painful other conditions that lead to painful periods?
Yeah, there have been a couple of studies to show that there is a link. These are all hormonal health conditions. They're all estrogen driven. So you can imagine that there is the problem, Rupi, is research is really crestfully very inadequate in women's research, considering we have a whole OBGYN specialty. But in my own clinic experience, I do find more and more, it really depends on how much time you spend with the patient, how much time you spend listening to the story that you can actually pick up. And so I do find that there is increasing, certainly as I am becoming more aware over the last decade or so, I've been picking up more women with coexisting conditions. And so it is, I hope somebody will do some more research in this area. But certainly, if you are having painful periods, please don't just assume it's PCOS, but instead, look out for other things. Ask the questions. People, as a health professional, as a doctor, it's our duty to answer your questions. And if we are not able to, then refer on to somebody who does know, because this joining of dots, hopefully when we talk about symptoms, I'll explain why it is so difficult to join the dots, which is why I want the person with PCOS in the center actually saying, what, this is what I think I have, because none of you are seeing me. You're seeing me in these different little groups of different conditions, and nobody's telling me that actually there is a common thread here.
Yeah, exactly. And on the subject of that common thread, let's talk a little bit more about insulin resistance, because I think this is not only one of the potential driving forces behind PCOS, but a whole host of other conditions, right? So everything from
Correct.
type 2 diabetes, dementia, cancer, there are links with this insulin resistance phenomena. You mentioned a few of those different drivers behind, or the causes of insulin resistance, one being environmental, genetic. There's also lifestyle factors, environmental toxins, sleep as well.
Correct.
Well, let's talk a little bit about exercise in the context of insulin resistance. What are the things that we know can potentially help us improve our sensitivity to this important hormone?
Exercise probably plays one of the key roles, I would say, to improving your cells becoming more sensitive to the action of insulin. And it works in many ways by modulating your glucose levels, but also improving the uptake of insulin. And we know that strength training or resistance training, especially in those with PCOS and in type 2 diabetics, plays a particularly good role. So when you incorporate regular exercise and bring in strength training, ideally at least twice a week, working different groups of muscles, we know that the cells become more sensitive to the action of insulin very quickly, actually. Similarly, when you look at having had a meal, if you actually get up and even walk for 10 minutes, that improves insulin sensitivity. So very simple things that we often have this habit of having a meal, the biggest meal at the end of the day in front of the TV, and the blood sugar levels never drop enough. So learning to eat within the circadian rhythm makes a very big difference for those with PCOS and those who have issues with managing blood sugars. But actually, who doesn't in this modern age, with all the stresses and things? So exercise, definitely a very big tick. Aerobic is also very good. In people with PCOS, doing high intensity interval training may not have the same benefits unless you're very used to it. Cortisol levels can rise, can worsen inflammation. I would always say listening to your body and at different parts of your cycle, and actually doing more energetic training in the first half if you wanted to, but more gentle training, yoga, Pilates, strength training, in the second half, and strength training throughout, really, for everybody. I'm menopausal, and I always tell women in the perimenopause and menopause, bring in strength training. It's one of the things that will keep your muscles working. And as we know, 1 in 3 people will die from a hip fracture, women from a hip fracture. So you want to build those muscles. And so it's for every age group. But PCOS, particularly, exercise and insulin sensitivity is, and we have a whole chapter dedicated to that, because insulin resistance is complex. It's genetic background, but also carrying excess weight really fuels the fat that is blocking each cell. And so when you lose a bit of weight, what happens is that fat moves away from the receptor site. And so it's like, imagine glue being stuck into a keyhole, which is the insulin receptor, and insulin is the key. So when you remove that gum or glue, then it works a bit better. The key turns a bit better. So that's why, exercise, while it's not good for losing weight, it helps with improving insulin sensitivity, but losing a bit of weight also helps to improve insulin sensitivity. So body weight does matter for insulin resistance. Genetics matters. Also the foods we eat. So when you eat foods very high in saturated fats, they also will worsen the effects of the cell, the way it reacts to insulin. So I hope people are getting a little sense of why insulin resistance is so important in polycystic ovary syndrome.
Yeah, absolutely. And I think, with all subjects in nutrition, it's influenced by a multitude of different factors, which makes it quite confusing for a lot of people. You mentioned
Yes.
age there, and I think, when you naturally age, you lose things like lean muscle mass, you naturally lose your diversity of your microbes. And so a confluence of all these different things, a reduction in your immune system, et cetera, leads to more inflammation, more insulin resistance, and the great preponderance of all these different things that we know it's related to. So it's a really important sort of just a broad strokes idea to understand all these different influences whilst we dive into these specific subjects. So exercise, super important. Genetics, something you can't really change, but something that you can definitely manage with, or better manage with better knowledge.
Correct.
I want to talk a little bit about the gut microbiome before we go into a sort of more holistic diet picture, because there is emerging research around the gut microbiome, which is this population of microbes that live in and around our body, largely in our large intestine. And these microorganisms play a role in insulin resistance, and disruptions to this gut microbiome can lead to overgrowth of certain bacteria that are less favorable, which can cause inflammation and alter the way our body uses glucose. I wonder if you could talk a bit about the microbiota in that sense.
Definitely. The gut microbiome is critical in hormonal health conditions. We know that in polycystic ovary syndrome, in endometriosis, if you look at samples of the gut bacteria, the vaginal bacteria, as well as bacteria from the peritoneal cavity, we know that there is a higher incidence of the ones that do not really bring health, groups like Shigella and things like that, Salmonella. So we know that there is disordered microbiome in PCOS, but we also know that there is a gut microbiome called the Oestrobolome. I don't know if you're aware of it. These are gut bacteria that specifically synthesize and metabolize estrogen that comes into the gut, which is normally meant to be absorbed and meant to be digested and excreted out, so you don't have excess estrogen. We know excess estrogen from our body fat, from some of our foods, can actually worsen the situation for us by increasing our risks of breast cancer and other estrogen fueled conditions like PCOS, fibroids, and endometriosis. So actually nurturing the gut microbiome by avoiding advanced glycation end products such as, fried foods and fatty foods, and really increasing the amount of fiber in one's foods, which, fiber is found only in plants. So trying to eat a wide diversity of food. So rather than just sticking to a narrow number of foods, because most people tend to eat, the same 6 or 7 dinners, so it's really thinking about what can I put on my plate. I absolutely dislike what I should not eat. I don't like what I should not eat. What I want to know is what I should eat. What should I put on my plate? And so I encourage all my patients to put more color on their plate. And so I see patients every single day, Rupi, where teenagers will tell me they hate fruit or they hate vegetables, or older women will say we are scared of fruit because we've heard fruit contains sugar. And so I have to spend a lot of time dispelling those myths, but also meeting the patient where they are at. So if a teenager tells me she hates vegetables, I ask her, okay, do you like cucumbers? Oh, I love cucumbers. Okay, so why don't we have a plate with cut up cucumber after school every day? And she said, oh, I can do that. And I like peas too. Okay, so the following week you add some peas, and then you add some carrots, and then slowly you start building up without them feeling overwhelmed, telling somebody to have 10 to 13 portions of fruit and veg. 10 to 13 portions of fruits and veg is actually not a big deal. It's about 4 or 5 fruits and a big salad. But telling somebody who doesn't allow a single piece of fruit to pass through their lips because they're on some fancy diet, you explain to them, do you like oranges? Oh, I like satsumas. Okay, do you mind having a couple of satsumas? We know they reduce the risk of endometriosis. Oh, I can do that. Okay, so do you think you could add a bunch of grapes to it? Oh, I love grapes. I thought they're so sugary. And so suddenly they're starting to eat some berries and some mangoes and some grapes. And you've got them on the path, and they're challenging themselves and thinking, I need to put color on my plate. That's what Dr. Bajekal has said. So it's just understanding that. Once you understand that, I think it becomes easier and not so overwhelming, not so judgmental on yourself, that I've been a bad person. I ate a piece of cake. So what? We're
Yeah.
allowed treats. Everybody's allowed a treat.
Yeah, yeah, absolutely. And I love that sort of holistic perspective you take of eating. It's not just one way. It's, meeting people where they're at. And I think, that speaks
Yeah.
to your decades of experience in clinical practice and seeing so many people, because you can't brute force this. And I think social media in particular sort of paints a very stark picture of what your diet should and should not look like. And in reality, it's flux, right? I'm going out tonight to a Thai restaurant. I know there is something on the menu in the dessert section that I absolutely love. It's this like mango parfait thing, and it's full of sugar. It's got all of that, not from the mango, but from all the other stuff they put on it. But I'm going to be eating that, and I'm doing that in the full knowledge of the impact on my insulin resistance. But over time, it's the consistency of one's diet that really has the
It's
impact.
not one meal, Rupi, and it's not one or the other.
Yeah.
It's not one or the other. People often think it has to be just one way. It doesn't have to be. Just like Western medicine can go side by side with lifestyle medicine. Similarly, a treat is a treat. You're allowed to have that treat. And that's why they're called treats. They're not meant to be everyday foods. So,
totally.
I think it's important to understand that.
Yeah. So just sticking with the subject of insulin resistance at the moment, you mentioned environmental toxins that I think is getting a little bit more airtime now, particularly as we know a lot more about POPs, persistent organic pollutants, and bisphenol A. I remember thinking and talking about BPA a few years ago, and I was sort of ridiculed by some of my colleagues about the impact on obesity or insulin resistance. And I think now we've got a lot more evidence to suggest that it is problematic and hence the banning of it. But I wonder if you can talk a little bit about how these environmental pollutants cause or related to insulin resistance and what we can do to mitigate that.
Yeah, I didn't finish that fourth reason, the insulin resistance with genetics, body weight, and with the foods that we eat. The fourth background reason we think insulin resistance is increasing are these endocrine disruptors. Endocrine disruptors are hormonal disruptors. They can actually go and not mimic or displace normal hormones, whether it's thyroid, whether it is your estrogen, whether it's your testosterone levels, so effects on egg quality, sperm quality, and things like that. And we talk about it in PCOS. We know that when you are exposed to BPAs and POPs and, if you think about most of the menstrual products, Rupi, most of them will have at least 200 chemicals in them, which is why I'm a big advocate of not just from, choosing environmentally friendly, skin sensitive, less pollutant driven, because you're putting these tampons and pads into very close contact, into very sensitive areas. And so one can start with those areas and look, how can you use more natural products? How can you change the laundry detergent that you're using that is actually more skin sensitive and more environmentally friendly with less harsh chemicals? We are all made of chemicals. We all have to have chemicals, but we are talking about harsh chemicals that will disrupt the hormones within our body and actually make conditions, whether it's obesity, whether it is cancer risk, whether it is PCOS, we don't know the full extent of all this. But what we do know is when you heat foods in these microwavable takeaway dishes and things like that, and plastics, so trying to go as plastic free, it's good for the environment, it's also good for you, it's good for your health, all hormonal health, male and female hormonal health. So I really would suggest that based on the evidence that is coming through, and there are studies now run by quite large environmental councils and people who are interested in it. City to See is a good account that I would suggest following as well, because they do a lot of work about these environmental pollutants. And I think it's important from a simpler perspective, rather than thinking, oh my God, I have to go completely plastic free. Start with simple things. Learn to store in glass jars or in stainless steel. Go back to my Indian roots,
Yeah.
doing little things like that can actually help. And that's what I have been trying to do, really focusing, making sure that when I go to the bulk food store, I'm actually using my own Tupperware and things like that. When I bring vegetables and fruits in, trying to take away the plastic straight away and storing them either in the fridge or outside without the plastic, looking at the kind of shampoos and the menstrual products, simple little things, because the studies are suggesting that it does disrupt hormones, whether it's insulin, whether it's estrogen, whether it's testosterone, whether it's your thyroid hormone. So I don't want to wait. I don't want your listeners, I don't want my patients, and I don't want us to be waiting for all the evidence to come out. We knew smoking was bad for us and caused lung cancer probably 50 years before a ban was brought in. So I'm not suggesting anybody waits for that. I'm not waiting to tell people don't drink, it's okay to drink alcohol, on a regular basis and go with the guidelines currently, because I don't think there's any safe limit. The studies are clearly showing that, but the guidelines are still not caught up. So
Yeah.
sometimes you just have to move ahead with times.
Yeah, I agree. And I really respect that, because I think, particularly within medicine, it is sort of frowned upon to go against or have a differing opinion to
Yes.
the consensus or the guidelines. And I think it's important as independent practitioners to weigh up the evidence ourselves and provide what we feel are safe, educated points of view and advice for individuals. And it would be pertinent, I think, to reduce the use of these synthetic chemicals through packaging from an environmental point of
Yeah.
view alone. I think no one would really argue against that. And I think you're
Correct.
right. There are plenty of studies that are coming out now that would
Yeah.
demonstrate the advice around reducing one's body burden of environmental pollutants. So, I mean,
Yeah.
I've done some very
I've
simple
never
things.
been.
Sorry, go on.
Mm. No. Carry on.
I was just going to say I've done some very simple things myself in terms of changing my cookware, changing what we put our food
Correct.
in terms of the types of containers. But at the same time, I don't allow the genuine anxiety I have around persistent organic
Yeah.
pollutants and BPAs and all the rest of it to influence, when I'm out at an airport and I can't get anything that's not being served in a plastic container. Like that for me is like, okay, well, I'm going to take the hit. And I also live in the middle of a busy city, inhaling the fumes and all the rest of it. And I think we have to
Yeah.
also respect how resilient our bodies are. So I think that's just something to sort of balance my perspective on these as well.
Yeah, I would definitely say there is always a balance. It's really important. There are days when you're tired and you want to have a takeaway. It comes in a plastic Tupperware. Nothing wrong with that. All you need to do is empty it out into your own dishes. Simple things that one has to do. There are huge advantages of living in a city as well, because of all the stimulation, the mental and emotional stimulations that you do get, and the wide variety of people and cuisines and things that you're actually exposed to. I think the community that we live in is also as important as the environment we live in. So yes, there may be pollutants, but it's a choice that we make, and it should not stop us from living our full life, and being really worried. What we do need to do is drive government policies and be aware of the policies, why they're being made, and support them. I think it can get very overwhelming if you start really. I think the stress, the emotional and mental stress of trying to lead this so-called clean life can actually be more detrimental in the long term. So I'm an absolute not fan of that. Equally, as I was going to say, I'm not worried about going against the grain. I have no issues about saying what I need to say based on emerging science and science. I definitely don't think that it's one or the other. I get really upset when I see wellness influencers disregarding or degrading or running down Western medicine, because we wouldn't be sitting here without Western medicine, without our vaccines, without, clean water. All these things have come through, with, through, antibiotics, the birth control pill, HRT, all these things are life changing for people. Pregnancy is a dangerous business. So it's not one or the other. It's not that you can't have the pill for polycystic ovary syndrome to manage acne or, excess hair, but there's also lifestyle. So it's not one or the other. People want to think that it has to be this 100% or nothing, and it's not. And I want doctors as well as the wellness influencers to know that it actually, for the person in the center, both might work. You can do everything with your lifestyle. You may have been handed a very bad genetic card, and as a result, you may have to take medications for diabetes or chemotherapy or anything. I'm don't knock that. Those have been proven ways. There are randomized trials and deep studies. Similarly, nutrition has been shown. So to my fellow doctors out there, lifestyle and nutrition does play a huge role. And
Absolutely.
you can see it all over societies all over the world.
Absolutely. Yeah, it's embedded in our culture for sure. You mentioned, just whilst we were talking about insulin resistance there, you mentioned the Oestrobolome and
Yes.
the population of microbes that are responsible for safely removing excess amounts of estrogen. And it reminded me of a section in your book actually that dived into this topic of estrogen dominance. So I wonder if, this term that's kind of banded around that perhaps is not as useful as many people would have thought. What are your thoughts on this term of estrogen dominance, and is this how we should be describing things?
The honest truth, it's BS. Okay,
go for it.
There is nothing called estrogen dominance. Okay, the body is very smart. What we are talking about is excess levels of estrogen in certain situations that actually worsen certain hormonal health conditions. There is no reason to assume that some of these supplements and things that people recommend will reduce estrogen dominance. Estrogen dominance there's a grain of truth in it, of course, Rupi. What I'm talking about are estrogen-driven conditions: breast cancer, fibroids, PCOS, endometriosis. These are adenomyosis. These are all conditions that are driven by hormones. But that doesn't mean that your estrogen levels are dominant in that situation. What you want to do by taking progesterone, you're not going to try and reduce that estrogen dominance. So you do need to focus on what are the things, what is going into your mouth, what is your body weight. Is that something that you can actually work on? Is it that, you have to take progesterone medications because you are not having periods, which means that you have unopposed estrogen, and that is increasing your risk of womb cancer. So you need to take progesterone and have a regular withdrawal bleed every 3 months if you're not having any periods at all and you're not on any hormonal medications. So that is what that grain of truth of the estrogen being in excess has been taken to become this really bandied term, which is why we've spent some time myth busting with regards to estrogen dominance, because it irritates me. Every time I see that word, it irritates me because it misleads people into thinking that if they took this supplement or that supplement or did this or that, they would actually be fine. And this is what happens when you have little knowledge, and anybody can have little knowledge. I'm not at all saying that doctors are the gatekeepers of knowledge, but when you have little information that is not backed by science, it can become a very dangerous place to be in. When you say things like beans are dangerous for you, or for example, that, if you don't eat 100% plant-based diet, you're going to die. No, of course, we know that there are a lot of nuances with nutrition. I choose to follow 100% plant-based diet, and because I know the benefits for me, for the environment, for the animals, but that doesn't mean to say that there is no leeway there, for people who are exploring or moving ahead, or their choice. You don't have to be 100% in anything. That would be going back to school and not getting that 100% and maybe people's parents asking, "Oh, you got 98? Why did you not get 100?"
Yeah. There's yeah, I think that the use of words and terminology that's banded around. I mean, even
Yeah,
casting the light on ourselves with the words PCOS, the abbreviation of it, that it can create an incorrect picture of actually what's going on. And so you're right. I
correct.
think just being aware of the terminology and actually how your body is reacting and what is driving the condition, I think is really important. Talking about joining the dots, so we talked a bit about symptoms earlier on. Are there other, I mean, how was Rohini's experience? How did you join the dots for her? And how would you want more people to better understand their bodies when it comes to potentially
Correct.
approaching their general practitioner or primary care physician with a suggestion that this could be PCOS or another hormone-driven disorder?
Yes. So it doesn't matter whether you are diagnosed ultimately with PCOS or endometriosis or hypothalamic amenorrhea. What is important, and we spend the whole first section of my book is understanding one's body. Because when there was a survey in London where you think, okay, there are a lot of younger people and they should know, 1 in 2 women did not know where their cervix was. 1 in 4 women in a survey in 2020 did not know where their vagina was.
Oh,
1 in 10 women did not know where their reproductive organs was. So this was, and these were not like 200 women, these were 2,000 women that were surveyed. So, and I find that in my own practice as well. You have these lawyers and doctors even who don't realize that the menstrual cycle should be between 24 and 35 days, and that missing periods is not acceptable. You may have PCOS, you may have an ovarian tumor, you may have an eating disorder, you may have be exercising too much, you may be having a completely other medical condition. But if you're somebody who's regularly having delayed periods beyond the 35 days, or you're having frequent periods under 24 days, if you are having periods coming every 3 months, it's really important to understand that that needs to be addressed. Okay, so first of all, knowing your body, understanding the different parts of your body, that the vulva is not the same as the vagina. Throughout the book, I try and explain these differences, because if you don't know your body, it becomes very difficult to advocate for yourself when you're sitting in front of the doctor's chair. I know for myself, I became menopausal at the age of 38. Had just become a consultant, and I still didn't know where to turn because I was not able to push for myself. And so if you don't have the knowledge, in those 10 minutes, your mind goes blank. You can't ask the questions that you have to. So writing down all the questions, we have a whole chapter, what you should ask your doctor, how to prepare for your appointment. It's so important that if you know your body, you can say, this is where it's hurting. This is what's actually happening. No, this is not what's happening. That's important for us to know. So that is the first thing. Know your body, track your menstrual cycle. There are so many free apps, and if you're worried about smartphones, write it down in an old-fashioned diary. You must know your flow. It's not your doctor who decides whether your period is heavy or not. You decide. If you are leaking, if you are somebody who's passing clots, if your periods are lasting more than 7 days, those things are big warning signs. So in PCOS, if you're having delayed periods or missed periods, that's one sign that you should be looking out for. The second is if you're having adult acne, especially after the age of 25, or painful cystic nodular acne at any age, especially on your chin, on all the hormonally driven areas. If you're having hair growth in areas like the inner sides of your thighs, or on your chest or on your chin, that needs to be addressed, especially if you're needing to, remove the hair every day, every other day. That can be really hard. Making sure that if you're having scalp hair loss, then rather than just going straight on to medications, actually delving in a little bit deeper. Do you have low iron stores? What is your diet like? Do you have PCOS? Those things are important. And then there are symptoms, Rupi, that we don't talk about. So one is, of course, carrying excess weight. When somebody is in a bigger body, what happens is you tend to get dismissed by doctors. And I have a whole chapter on medical racism and medical sexism and medical weightism or sizeism, because we know that historically that has been the theme. And so what happens is once you feel dismissed, you will then end up not seeing the not approaching doctors again. And so you then end up suffering in silence. So that's another sign. Infertility or having difficulty in conceiving is the most common cause of infertility is PCOS. And that is because, if you remember, I was talking about releasing of eggs, the ovulation. Because of anovulation, you're not releasing eggs, you're not having periods regularly. That is the most common reason for infertility or difficulty in conceiving. Most women will go on to conceive with or without help with PCOS, but don't again be dismissed by your doctor just because you're young. If you have a diagnosis of PCOS or endometriosis or any hormonal health condition, if it's taken you longer than 6 months, don't wait for the 18 months. You need to push and say, I need tests, I need investigations. Take that power into yourself. So infertility, excess weight, all the signs of androgen excess, period issues are symptoms of PCOS. But then you have symptoms like, the mental health symptoms, obsessive compulsive disorder, never gets talked about, suicidal thoughts, binge eating. Can you imagine when you're already living in a larger body, you then go to the doctor and they tell you to lose weight, and you're actually, a high proportion of women with PCOS have binge or disordered eating without anorexia, so without purging. So what happens is you tell somebody to lose weight by either going on even on a plant-based diet. That is very triggering. So weight loss should never be, even though it's a great way of managing polycystic ovary syndrome, focusing on a health goal is much better. I want to run a 5K. I want to go for a walk with my friends. I want to be healthy. I want to have a child. Whatever it may be is a better health goal than a weight loss goal. And then anxiety and depression are huge components of PCOS because the condition is very stigmatized. You don't have many celebrities coming out, because of the fact that it involves acne, loss of hair, excess weight. So you have few and far between celebrities talking about it, and nobody wants to, talk about conditions that have been sort of made fun of in the past, right? Male hormone, you look like a man, these sort of situations. And then there are sleep issues, disturbed sleep, snoring, sleep apnea. These are all symptoms that are not talked about, thickening of the skin and darkening of the skin, which is sort of a marker that you have insulin resistance, called acanthosis nigricans. So there are so many symptoms which don't fall into the criteria for PCOS, but really are so disturbing. Psychosexual dysfunction, body image, people stop going out. Rohini was in that situation. She didn't want to go out. And so if you just label somebody, with anxiety or depression without actually understanding what is the background, not taking the time, you're doing the person a real deep disservice. And because there is so much help available, that is important to understand.
Yeah. I wonder, with your perspective, having worked in such a busy healthcare system, and I'm sure you've got plenty of colleagues and friends who work in general practice as I do, the strain on our healthcare service today is one that pushes a sort of pharmaceutical first approach because it's quicker. And it's according to guidelines, although I'd argue that lifestyle is very much part of the guidelines as it is in NICE at the moment. But do you think that this is a situation now where we have to really start thinking laterally about how we rely on at-home investigations, telecoms and telemedicine and telenutrition that I don't think is getting enough airtime, as well as companies that provide direct-to-consumer testing so people can take control of their own health? I think there are pros and cons of that for sure, but the way you've just described everything in terms of how we assess symptoms, it is in direct contrast to how I hear other general practitioners being able to practice with the time constraints that we have today. So I guess my question is, what are your opinions on D2C, at-home investigations, and telenutrition?
I am actually a great fan. I do believe that we don't credit the public and our patients with enough knowledge. They're very clever. They know what they're doing. It's just important to empower them with the right evidence-based resources. And I think that's where we come in. I completely understand that my colleagues and GPs are very hard pressed for time. That is why I say to everybody who's listening, prepare your questions, make sure that you have what do you want out of an appointment. Have two or three top questions that you want answered so that you get them answered. But also to my fellow colleagues, I would say, try and hand out some resources. Don't have to even say very much. Just, in the 10 minutes, say, I hear what you're saying. Perhaps this is a resource, a nice guideline or a Monash guideline or Dr. Bajekal's website. It doesn't matter what it is. Give them a guideline that is science-based, evidence-based resource, because you just don't have the time, especially when you're seeing 20, 30, 40 patients. You may not have the time. But what you do then is you set the scene for that person to start understanding about their condition, which means they will take less time next time. Maybe they won't even need to return to you. And also, there is absolutely no problem if they do decide to have tests, but I would warn against choosing clinics and sites that are not expert validated. So, for example, we know with hormone therapy, there's a huge, it's a whole different chat and a podcast would be, but we're talking about bioidentical hormones and people having urine assays and serum assays, and those are all actually, again, not validated at all. They, in fact, maybe, not just cost you money, they might actually hurt you in the longer term. So definitely, there are very good sites where you can have your blood tests, but make sure that you get your doctor to interpret them rather than somebody who is not qualified to do that. I think that's really important.
Yeah.
But providing people with resources, and coming back to this thing about medications are very important. The pill is one of the first line treatments for acne and for hair growth, because for that young woman who can't step out of the house because of her clinical symptoms, that's a great place to start, especially if she doesn't want to get pregnant, especially if she's not having periods. But even every international guideline is very clear. Lifestyle and behavioral changes have to come either side by side with medications or before medications for polycystic ovary syndrome management. And that is a huge shift. My only beef with that, and one of the reasons I wrote the book with Rohini, is that it's all very well to tell somebody go and have a healthy lifestyle. The patient groups on those panels said, hang on, you're telling us to do this behavioral changes and lifestyle changes, but you're not telling us what we should be eating or what we should be doing. You're telling us any diet will work. Well, yes, any diet will work if you do calorie restriction. You can smoke your way into losing weight. But actually having something that is time tested, is proven to be helpful. The global burden of disease study in the Lancet, 195 countries, showed that 11 million deaths can be prevented by just eating some more fruit and whole grains. And so it's important to understand that you have to give people guidance as to what they should be doing. How they choose to use that dietary advice, the exercise advice, the stress and sleep advice is down to them. But you have to give them the science-based knowledge about it. And so I think it is key for us to give those resources and guide people to the right places. And then you have to respect the individual. They have to decide for themselves. They are in the driver's seat. I am not watching over their shoulders to see whether they're eating a donut or whether they're eating a piece of fruit. I'm not interested in that. I want people to take responsibility for themselves. And I think doctors should learn in many ways to hand that responsibility to the patient, but in a way where they're guiding them rather than, saying, take this medication, off you go, because that's not going to be helpful, because then they will fall prey to, people who are telling them the pill is really bad or metformin is bad or, just have loads of supplements. We don't want that situation. We want it to be the best for the person so that it actually helps them live the best life that they can.
Yeah, I think this really leans into the art and science of medicine, the science being the use of pharmaceuticals, even nutritional medicine, being aware of the studies.
Correct.
But then the art is the ability to empower your patient, to help them achieve a new self-identity that propels them forward on a lifestyle that they have to, continue themselves. Because, in the context of your week or let's say month, you might see your doctor once or twice out the entire year. That's 10 minutes. The rest of the time you're with yourself. And so actually the way I've been reframing my own practice is how to get people to engineer a life that they can sustain and maintain. And consistency is something that I'm just super obsessed with at the moment, and creating habits that stick. I think when we develop sets of tools for different people that leans into that, that's when we can actually move the needle on healthy lifestyles. And we mentioned diet, and we've been darting around it now, but I wanted to talk about some of my favorite topics, which are beans, first of all, and the ingredients.
Love beans.
Yeah, I love beans. And the anti-inflammatory diet that we just mentioned there as well, in terms of the different types of ingredients. So in a broad strokes picture, I know in the book you've got a lovely image of half the plate being fruits and vegetables, then you have your starchy, and then you have your plant-based proteins, which I think is a really good guide for a lot of people, just to have a heuristic, a rule of thumb when they look at their plate for breakfast, lunch, or dinner, or whatever. But what are the kind of ingredients that you like to sort of talk to people about? Obviously, with the caveat that, it depends on their personal preferences and tastes.
Totally. What I want people to understand is that I would like them to inch forward to eating a whole food plant-based way of eating, not a vegan diet, not necessarily a omnivore. It doesn't matter what you eat. As I said, I want you to focus on foods, especially for hormonal health conditions, eating plenty of fruit, plenty of vegetables, especially green leafy vegetables. The reason I say this is because it's full of antioxidants and phytochemicals, and polycystic ovary syndrome is a condition of inflammation. Inflammation is a building block for many conditions, whether it is obesity, whether it is PCOS, whether it is some cancers, hypertension, heart disease, type 2 diabetes. We know inflammation is a big issue. So we want to try and reduce that inflammation. So how do we do that? I try and encourage people to bring in more fruits into their diet, more green leafy vegetables, colorful vegetables into their diet, whole grains. So I'm talking about brown rice and quinoa and barley and oats, and experimenting with different ancient whole grains, whatever they feel like. It's all very good. The less processed they are, the better. But there are some foods, processing is not bad. You just don't want them to be ultra processed, generally, as far as possible. You want to also have a lot of legumes, and legumes are basically, beans fall into the group of legumes. They're all very rich in fiber. They're rich in micronutrients. I don't like focusing too much on macronutrients, but micronutrients, beans, green peas, soya, pulses, which means dals and things. These are all fall under the group of legumes. They are my favorite group. I think they come packed with so much nutrition, so much fiber. They help to reduce the inflammation. We know that long-living societies like the blue zones all over the world tend to eat beans as a staple. I want people to eat starchy vegetables, so things like potatoes with skin. Ideally, you want to cook your potatoes and then put them in the fridge and then reheat them, because that increases the resistant starch. And when it increases the resistant starch, your blood sugar levels don't spike. So potatoes are a great source of nutrition, helps to keep you full. I also want you to have sweet potatoes and yam and other tubers. I would like people to bring in mushrooms, a lot of mushrooms. I'm a great fan of mushrooms. And so I know it's not part of the lifestyle ACLM's group of plant-based foods, but mushrooms are a firm favorite of mine, as well as herbs and spices. Really important to bring in herbs and spices, and making water your drink of choice. So herbs and spices are particularly important. So for example, putting cinnamon on your porridge in the morning or on your cereal will help to stabilize blood sugar levels, digestion with cumin and things like that. So I have those tips in my book, but it's really important that we understand the power of herbs, throwing a sprinkling of coriander or parsley or basil, whichever herbs you like, fresh herbs. spices. They can stay forever in your in the fridge if you wanted to, so but buy smaller quantities. I always tell people, shop at the end of the day. Try to, if you're on a budget, if you're a university student, go to the local market, go to the world markets, go to the supermarket when all the prices are down. I remember Rohini used to shop in Marks and Spencer in Huddersfield when she was doing her nutrition degree, and at 8 o'clock at night, just before they were going to shut down, everything was like 10p, all the foods that nobody had wanted, the beans and things like that. So I think it's important to really focus on these foods as much as possible, keeping a leeway that if you're going out, you can have a meal out once a week. And in our 21-day plan that Rohini has formulated, there's space for all that. Because as I said, if you're going to think this is not a joyful way of living, which it is, it takes time. So give yourself the 3 to 6 months of eating this way, rather than thinking I've got to go 100% plant-based. I've got to be like this amazing person who's cooking every meal from scratch. Cans are bad. No, try to buy BPA-free cans. Try to buy stuff that comes not necessarily in paper and things like that. But it's not the end of the world if you're using a can of beans instead of having a takeaway. You can just make a very quick meal out of canned. And I'm a lazy cook. I love cooking, but I'm a lazy cook. Anything that takes me longer than 15 minutes, out. Not in my book. Not in my kitchen. So I don't like all this long stirring. No, not for me.
Yeah.
So this is what I want people to eat. And maybe if we have time, we should talk a little bit about soy, because again, it gets such bad press.
It does get a bad press, and I'm a fan of soy. I have tempeh in my diet. I have tofu in the various forms it comes, like soft, medium, firm texture. It's a very versatile ingredient, and particularly if you're trying to lower your animal product consumption as well.
Correct. The reason why I'm such a fan of soya is a bean, okay? It's a magic bean, like Jack and the magic beanstalk, but it is a bean. And so it's given so much more importance than it actually is. It's just a poor little bean that has been around for about 5,000 years. And all the, whether it's China, Japan, Korea, all of them have been eating soy. So we know it's healthy. There's not been any studies. There have been thousands of studies showing the benefits of soy. There has been zero scientifically based studies. There's been one case report, I think, where somebody drank 20 liters of soy milk, but for men and then developed some excess amounts of estrogen. The beauty about soy for all hormonal health, whether it's male or female, is that what it does, it has fiber, it has protein, very good amounts of protein. In fact, soy has the similar amounts of protein to egg white, which is considered the holy grail for people who work out. And so you want to understand that not only does it have fiber and protein and lots of micronutrients, it also has plant estrogens, isoflavones, which are present in flaxseed, which are present in, cereal and fruits and pistachios. Soy has the same thing. And what this clever bean does is these plant estrogens block the effect of the more dangerous excess mammalian estrogen. So that coming from our body fat, that coming from, say, dairy and red meat. What it does is, because it works on the beta receptors in the cell, not the alpha and the beta receptors, it goes and promotes the growth of bones and reduces your risk of osteoporosis. It reduces hot flushes. It helps to lose weight. It protects the heart from those beneficial activity, but it also has a blocking effect, which is why it reduces breast cancer and prostate cancer. We know that those who consume soy earlier on in childhood, and in early adulthood, have a 25% reduction in aggressive prostate cancer. And it also reduces colon cancer, ovarian cancer, womb cancer, which is important for PCOS, breast cancer, liver cancer. So because it's basically an anti-angiogenetic action that it has. It basically stops the new blood vessels that fuel cancer growth. And it also helps with the heart. So I want people to have at least 2 portions. If you have a thyroid problem, what I would suggest is making sure that you have a couple of hours between taking your thyroxine and your soy milk or tofu or whatever you're having, because it can compete for the same receptors. But otherwise, between 2 to 4 portions, which means a glass of soy milk, a handful of edamame beans, a tempeh burger, a handful of tofu. I tend to have about 3 to 4 portions of soy every day, but depending on your level of activity. But this is because you don't want to displace other healthy foods. So you don't want to have 20 portions of anything. You don't want to be on a fruitarian diet. You want to be having fruits and vegetables and beans. You want to have a diverse diet. That gut microbiome that you were talking about, it loves diversity. The American Gut Health Project suggested that we should have at least 30 different plant foods in a week. How do you do that? You have to have salads before every meal. Great way to help reduce weight. Great way for the taste buds as well. It also helps you fill you up with the right things. You understand? So I think once you get this way of eating and not demonize soy because it's got plant estrogens, you should actually celebrate soy because it has plant estrogens, just like flaxseed has and pistas have and what do you call it? Cereals and various other beans. They all contain plant estrogens. We don't stop eating them. We shouldn't stop eating soy.
Yeah, exactly. Yeah, I think it comes down to what we were discussing earlier about the lack of nuance and the sort of loose associations that one might make if they don't understand the science. It's kind of like, cholesterol and phytosterols. You want to have phytosterols. Yeah. You wouldn't reasonably think that if you eat phytosterols, your cholesterol is going to go up. Or your LDL, your carriers of cholesterol are going to go up. So it's the same thing, and actually that's been demonstrated to be beneficial in the portfolio diet and a whole host of other diets as well.
Totally.
So I'm glad we've touched on that for sure. Although I'm sure there's going to be lots of other questions based around soy that we have to tackle. But you've gone through a lot of them in your book. I imagine when you've talked about these sorts of ingredients in your patients' diets, your patients have come back to you and like, Dr. Bajekal, I've tried getting more beans in my diet, but I just bloat, or I eat this way and I just bloat. You've got some tips on how to avoid bloating as you inch toward, I love that term, that inching toward a whole food plant-based diet. What are some of your tips that you talk about?
Yeah. So the other thing I want to mention, Rupi, is that, just because one has been diagnosed with any condition, it does not mean you can't eat culturally appropriate foods. Every single diet, especially a lot of our diets around the world, whether it is an Italian diet, whether it's an Indian diet, whether it's, Southeast Asian diet, doesn't matter. There are a lot of beans and legumes in these diets, but also you can enjoy those foods. I want to enjoy my idlis and my dosas and my, different types of rotis and dal dosas. I want to eat that. I don't want to always be having avocado on sour bread, for a treat. So I think it's important to know that all these foods can be adjusted. And that's how when I changed my diet, because Naina, our younger daughter, decided to go completely plant-based when she was 10. I brought in so many world cuisines, which I never knew existed. And so for those who are struggling with beans or any legumes, start with the smaller beans. That's what Rohini explains. Always start with the dals because they are smaller, they're more easily absorbed. Start with making sure that they're completely cooked. So they should be soft, mashable with the back of your spoon, whichever bean you're eating, because undercooked beans can give you a terrible tummy. The second thing is so making sure that you rinse your beans from a can thoroughly, cook your beans, soak them in hot water or in water and come back in the end of the day or overnight and then cook them. They cook faster, easier, they're softer. Start with just a teaspoon. Start with a teaspoon on your salad or something and then make it a tablespoon. Then make it 2 tablespoons. The same approach that I have with my patients. You don't eat any vegetables, start with one vegetable that you like. So same way, start with a teaspoon, then 2 teaspoons or a tablespoon, and then suddenly you're eating 3 bowls of dal and 2 bowls of lentils, and there's no problem. There are certain spices that I advise. One of them is called hing or asafoetida. It's got a a funny little smell, but you don't smell it once you put it in, and you just need a little pinch. I had to change all my recipes from a pinch to a quarter of a teaspoon because I'm so used to just throwing things in. So when I teach cooking in the community class in Made in Hackney, I have to really think about the amounts that I use, because as I said, I'm a lazy and a quick cook, so I have to really adjust to that. So using some asafoetida while you're cooking your beans, or into the tarka, as we call it, the seasoning, can really help with reducing bloating. And again, making sure that you are avoiding foods like dairy and things alongside, because what happens is the gut microbiome is completely different in those who have a plant-based diet versus somebody who's having quite a lot of animal products. And that can give rise to, because those bacteria don't know what to do with beans. And so you can have a lot of bloating. So introducing them slowly over a period of 3 to 6 months, as you slowly replace some of the other foods, you will find it much easier. I haven't come across too many people once they adopt this. The problem occurs, I think, when somebody watches a documentary, and goes completely plant-based or vegan, and they don't know what to do. They just remove the meat from their diet. And so the star of the show, which was the meat, is now gone, and they don't know how to bring in the plant protein or how to bring in a beautiful variety of plant foods that just fills your heart with joy. It's a joyful way of living. There's no deprivation here. I can tell you, I eat everything that anybody else on this planet eats, in different forms. So I just think it's useful to remember that it has to be a journey. You have to do it slowly if you want to sustain it 5 years, 10 years, 20 years, right until the end.
Yeah. I think those are awesome tips, and I think the speed at which one transfers or changes their diet has a lot to do with the bloating. I always say that you've got to go slow when you're increasing the fiber content of your food, and you're adding new diverse sources, and try different things as well, but in small amounts. So I think that teaspoon to tablespoon to maybe half. I mean, I have a lot of beans in my diet, and I'm completely fine with bloating, but that would have been very different had I had a very heavy animal-based diet. And actually, a lot of people, I don't think, realize just how many animal products they might consume on a day-to-day basis. My consumption is very, very low, but most people unconsciously will consume smoked salmon in the morning, a couple of eggs, chicken for lunch, and then maybe a steak at dinner. A lot of people are having this kind of diet. It's completely reasonable and normal, quote unquote. But actually, when you start changing it, that's when you see the bloating and stuff. So, those are really good tips. Apart from,
it's like when you're bench pressing. When you're bench pressing, for example, you don't suddenly bench press your whole body weight straight away, right? You've got to slowly build it up. That's the analogy to use, that you can't, or you don't suddenly run a marathon if you haven't even not able to run to the top of the road.
Exactly.
You just can't. So I think that is the people want very quick fixes, because they're often promised by people who don't really reveal all of themselves in social media. And what happens is you're suddenly seeing this person who's at the perfect size, everything seems so perfect, and they're eating this, huge salad, which is great, but they've been doing this over time. So how can you suddenly jump to that when you haven't eaten any of that foods? You wouldn't do, as I said, you wouldn't run like that, and you wouldn't lift weights like that. So don't do it with food either. And also, you don't have to start with food. There are 6 lifestyle pillars. So I often, my way of approaching when I talk to patients is I never start with food. I'll say, after I've asked them their gynae history and their general history in about 5 minutes, what I always ask them all the general stuff and then focus in on the gynae stuff, because otherwise I can get distracted and forget that they're allergic to penicillin or something like that. So I have a system that I actually work through. And then I said, would you mind if I ask you a few questions about your lifestyle? And I always start with sleep and stress and exercise and their alcohol intake and their smoking and their community support, and then go to nutrition, because then people don't feel so judged. Nothing makes people feel as judged as to what you eat. You're always apologizing either for being a vegan or for being plant-based or for eating a steak. We're always apologizing for things. So I think it's better to work this way, and also by maybe focusing on, if for me, of all my lifestyle pillars, sleep is absolutely. I so always say I'll sleep when I'm dead. Most of my life I've slept 4 or 5 hours. I know it's terrible. It's probably the thing that's going to kill me very quickly. But that is where you want to focus a pillar that somebody is actually interested in. I think I do want to do 10 minutes of app where I will do some mindfulness, or I'll go for a walk. I can do that. And so what happens is the domino effect. When I go for a walk with a friend, I laugh. I feel better. My stress levels come down. When I come home, I am not reaching straight away for a piece of cake. I will say, you know what, I'll actually have a tub of strawberries. And so when you do that, you feel better. You then tend to sleep better at night. When you sleep better at night, you'll wake up and have the porridge. And so you'll not reach for the glass of alcohol. So I just think that working with people and actually focusing on perhaps the other 5 lifestyle pillars before you dive into nutrition sometimes can be a nicer way, and not making people feel judged that much, at least, certainly, unless that's what they want to first. You might give them a couple of tips, but focusing on one of the other lifestyle pillars might be a kinder entry into helping them empower themselves, because we are as humans quite harsh on ourselves, especially women. We're very harsh on ourselves.
Yeah. I'm really glad you mentioned that, actually, because I think we all have our biases, right? Whether it's a particular way of eating, or whether it's a particular intervention that we favor, a particular lifestyle pillar. And you have to match that to where someone's at and what they're most motivated by. So I think it's really important to remember that. And this might be a little bit of a segue, but you strike me as someone who's energetic, joyful. I mean, this conversation has been an absolute pleasure to have. I mean, what are the things that spark joy in your life? Because I mean, I've seen you in a few other pods. I've met Rohini. It kind of shines through her as well, I feel. Like, what are the things that are like really giving you joy at the moment? Also considering the fact that you've been working super hard in the healthcare system for many years now. Where are you getting your sort of sources of inspiration and motivation?
It's not always like this. I can tell you. I'm an anxious person. I am an introvert, actually. I do love my own company, but I could not have been happier that I fell into medicine. I had no idea that I wanted to be a doctor. I had polio as a kid, and I recovered from it. It was just before the vaccine, so I'm 61 years of age, so long time ago in India. But my father really pushed me in the track and field event, so I was hoping that that's the road I was going to take. But of course, in India, there was no system to do that. So my brother and sister were doctors, so I became a doctor. And discovering OBGYN was the best thing that ever happened to me. I just find it just as thrilling as I did 40 years ago. But over time, I realized there was something missing in my toolbox, and that was lifestyle medicine. So I then retrained, having gone through a very difficult time at the age of 38, with premature ovarian insufficiency, a menopause much earlier than my sister or my mother went through. And I didn't know where to turn. I'm very honest, Rupi. It was really hard. I couldn't share with my male colleagues, and I should have, because they were so supportive later. And I was always this overachiever, I wanted the gold medal. I wanted to be the top of my thing. I never went part-time. I went back to work straight away. I had a fantastic support in my husband, who I met in medical school in first year. So, we pushed ourselves. We were immigrant doctors, poor immigrant doctors, but we never thought we'd stay on in the UK. 30 years later, I'm still here. I wanted it at my terms of being a consultant, reaching the top of my game, and really helping people. So I think my joy comes from a few things: from my family, I just adore my family. I adore my 2 rescue dogs. Walking them is not negotiable, whatever the weather. They get 2 hours from me and 2 hours from Rajiv always. The NHS was a great source of joy for me because I loved the way it delivered care, free at point of care, and I loved that. It's one of the main reasons I didn't go back to India. I do private practice and actually just retired from the NHS after 31 years, and I do still do a bit of private practice. But I think the fact that I want to reach a lot of people. If I can change somebody how they think, maybe help them, because I see that every day in my practice in medicine. I see people who get their periods back, who get pregnant, who have health goals that they have achieved, have come off insulin. So, for me, that is something I want to take on a bigger platform, just because if somebody hears this, makes one little change for themselves or their parents or their children or the community, because women are great at chatting, aren't they, and sharing information. I just want that information to be out there. So that's what gives me joy. In my spare time, as I said, walking the dogs, watching endless box sets, and chick flicks. I cannot watch anything that is remotely upsetting. My brain doesn't take it. I cannot. I start feeling for everything, and it's not a good place to be. So worrying continuously about the planet, about animals, my mental health really suffers, and so I need to be outdoors. I play golf. And I have a very good friend support. I'm part of a book club and things. So it's tough. People who think that, yes, I am very jovial, I am very upbeat, I love what I do, I'm very passionate, and I have found the purpose in my life. And I think if I hadn't gone menopausal that early, I probably would never have found it. So there's, I do practice gratitude, however cringe that sounds, but I think that there is a lot to be said about the different aspects, and actually acknowledging, I went through, my children said, if there's one thing you can do, mom, go to therapy, because I think you will benefit from it. You're always never putting yourself first, always pushing the boundaries. And I have to say, it's been an absolutely enlightening experience over the last year or so, because there are so many aspects that we don't want to think about and talk about. And it's useful to know that, not everybody is what they appear on the outside. There are a lot of things that do go on that, and I think had I not had the therapy, I've recently had a few health issues in myself and in my family, which are all under control. But had I not had the tools to deal with it, I think I would have been in much worse place. And Rajiv's been an amazing partner and my soulmate. So I've been very, very fortunate, and I want to use that good luck and fortune to try and reach out to people. So
Yeah.
I hope that didn't sound too long or
Yeah,
cringe,
no,
but
no. I mean, I appreciate you sharing that. And I think it's very easy for people, like I have just done there, to assume if you're joyful on the outside, you're joyful in every aspect of your life. And I think I was chatting about this with a couple of colleagues and Owen actually on the podcast about how I need to demonstrate slightly different sides to me, because a lot of people would make the same assumptions about myself. I'm always jovial, I'm always excitable, I'm always energetic, but there are days, fairly often I would say during my week, where I do get low and I do have a ton of self-doubt and I do self-criticize and I feel like I'm in limbo and I'm not moving anywhere, or I'm not going to the next goal, or I'm not being aspirational enough. And I think that plagues everyone, and in particular certain types of people who find themselves in professions like ours, in medicine, and to know that
imposter syndrome.
exactly, and to know that you were in a competitive field prior to medicine, and you're already of that sort of that mindset, probably gives me a little bit more insight into why you might be an anxious person as well.
Yeah, I think what my father said to me always, Rupi, which I think my mother and father were really inspirational people, but couple of bad things my mother handed down to me. She was, they didn't have much money, but so she worked really hard. She was a head teacher and she held down 3 other jobs. But that was the role model I saw and which I've handed down to my children, which, there has to be a balance in one's life. Going back to work within a few days of, having your first child is not something I would ever advise my trainees. Not sleeping at night, wearing it as if it's something really good. I'll sleep when I'm dead is not something, those are lessons that I wish I had learned all those decades ago. But the other beautiful thing that my parents would always say, especially my father would say, is he never brought me up to be competitive with anybody else. And I'm not sure whether it's a good thing to sort of compete with yourself, but basically try to be the best person you can, because, there's always somebody going to be, cleverer than you, richer than you, more beautiful than you, more successful than you. What are you going to do? You have this one life. You've won this lottery of being alive at a time when, I'm so fortunate to have health, to be a woman, not being in an oppressive regime. So many benefits, so many good things that are happening. If I'm going to look at the negatives, that's going to really drag me down. So that I think is really important, that don't look at other people, how they are doing. Look at yourself and think, how can I make myself happier? Will the next book make me happier? If yes, go for it, but do it nicely, because that's what I have to keep telling myself, understanding that is really the critical bit is, you have that one life, it's your life. And if you don't live it the way you want to, I can't be you, Rupi, ever, right? And you can't be me. So what is the point of trying to mimic somebody else's life? Because you're not going to, it's never nothing. Not your genetics, not your epigenetics, not your environment is ever going to let you do that. You'll just be miserable about it. And also understanding that you can't change the entire world. You can do it one person at a time. And that's what I have to talk to myself always, because I can, I swing through, oh my God, we're heading to doom, the planet is gone. What is the point of me talking about all this? It's absolutely useless. And then I talk to somebody like you and I'm thinking, wow, there's so much hope in this world. It's so lovely.
That's so lovely of you to say.
I love seeing young people, and young people are the future of this world. I have to say, I just absolutely adore young people.
Yeah. Well, I'm a gratitude proponent. Like I share my gratefulness everyday exercises all the time with friends, colleagues. I used to share it on Instagram. I should probably start again. So I'm a big fan of gratitude, and also. There is this concept of mimetic behavior. It was pioneered by Rene Girard, and I would definitely look into that because I feel that as humans we have a natural inclination to mimic. Is actually how we've evolved. And I think when you understand why we compare each other, or why we get FOMO, or why we always feel that we need to benchmark against other people, it's actually part of our evolutionary drive. And when you understand that, then you can make steps toward healing that. Because I have to remind myself that comparison is the thief of joy pretty much every day. And
totally.
and I think, we were joking about it earlier, and there is sort of a running joke, particularly amongst people who come from an Asian background, whether it be Sri Lankan, Indian, different parts of China and other parts of Asia, that the parenting sort of technique is, if you've got 98%, you're missing the 2%. And where's that 2%? Why didn't you get that
Absolutely.
extra 2%?
And I was so grateful to my parents for that. They never did that, but I've seen it all the time. I was a terrible parent myself, in the sense that the girls basically brought themselves up. Seriously, Rajiv and I were the world's worst parents, I think, because we were so busy with our careers, the girls literally brought themselves up, and thank God they did, because they did a
Yeah.
brilliant job, because they were too clever for us and we couldn't answer half their questions. So it was absolutely fine whatever marks they got, because we never saw what they got. But it's a recurring problem with
it is, and I feel that there needs to be almost like another division, or at least an appreciation within therapy that is practiced in the UK or US, or if you like to call it Western therapy, for people of Eastern backgrounds, particularly immigrants. I think there's a real lack of appreciation for those sort of households and how parents engage with their kids and what is regarded as the norm. And I've had therapy sessions where I've basically had to explain the typical Indian or Asian household for a couple of sessions before they actually appreciate that's where you might have trauma or ingrained beliefs that are not helping you in the present moment and your day to day. So we could probably go off in a completely different direction, but
but you're right. I mean, I just want to say this. Naina, I remember when she was young, or even recently, we had a chat, my younger daughter, and I said, I never put any pressure on you. Dad and I never put any pressure on you. And she said, yes, you did, just by being yourselves, just by being Indian, just by being the doctors that you were, you put pressure on us. You do not realize. You think that's not pressure, that is pressure. And that's the same with health things as well. I think there's not enough appreciation of the stress that generations before us and generations like myself have come in, the stress that it has on our health, on our environment, that we pass on to our children. Those things have not been appreciated in research, have not been appreciated in nutrition, in so many aspects, that I think I'm so glad to see people of color now in platforms where they can actually hopefully make a difference, where you see somebody who looks a bit like you, who is has got a similar background to you, which allows you to then say, you know what, I can also do this. Like you said, with mimetic behavior.
Yeah, absolutely.
Yes, we can go on forever. So I think.
Nitu, this has been wonderful. I'll have to get you in the kitchen studio whenever it's built and whenever it's ready and stuff, and you can cook up some of the dals and the idli and dokla, whatever you want to cook. I'm sure it will taste absolutely fantastic. So thank you so much. I really appreciate you.
Not at all. Thank you for having me on.